have organized this event. Before we get started, I'd like to acknowledge that I'm hosting this webinar from the lands of the Gadigal people of the Eora Nation. I also acknowledge the traditional custodians of the various lands on which you all work today, and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. Tonight, I'm co-facilitating this webinar with Dr. Rita McMorrow from the University of Melbourne and Dr. Liz Sturgis from Monash University. I'd like to hand you over to Rita now, who is the president of the AAPC ECR subcommittee, who will briefly introduce the AAPC and membership for a non-member audience. Over to you, Rita.
Thanks, Yun, for that introduction. As Yun said, my name is Rita McMorrow and I'm the chair of the AAPC Early Career Researcher and Capacity Development Subcommittee. So we are a group of diverse PhD candidates and ECRs from around Australia and New Zealand. And as part of our role in AAPC, we run a peer support group called FACES, which stands for Friends Advancing Careers Through E-Based Support. We meet every second month to discuss a topic relevant to ECRs and primary care research while building our peer network. So we wanted to take this opportunity to welcome any members to join our FACES group or indeed join the AAPC ECR subcommittee membership committee. So please feel free to visit the AAPC website to find out more information to join either of the groups. Thanks.
Thanks, Rita. So we certainly hope to see some new faces at the next ECR committee meeting. Our speaker tonight is Dr. Jean-Frédéric Levesque. Dr. Levesque is Chief Executive of the Agency for Clinical Innovation and Adjunct Professor at the Centre for Primary Healthcare and Equity at University of New South Wales. Dr. Levesque is an international leader in healthcare system analysis and improvement, with a career spanning 20 years in clinical governance, healthcare policy, and academic research. Tonight, he'll reflect on his diverse career experiences to discuss opportunities for collaboration between academia and government to drive service improvements. If you have any questions for Dr. Levesque about his talk, please enter them in the Q&A box next to the chat function, and Liz and I will read them out after the presentation. So please join me in welcoming Dr. Jean-Frédéric Levesque. Over to you, Jean-Frédéric.
Thank you, Jan. Can you hear me well? I'm going to share my screen to start the process. All right, excellent. Thank you, Jan, Liz, and Rita. It's a real pleasure for me to be here tonight and give this webinar. Although I have to say it was also a bit of a challenge. It's always a bit of a daunting task to reflect on some of your time in research and in policy making and etc. And I wanted to take an angle that would bring a bit of a mix of theory, bit of evidence. Of course, I like evidence, so I will bring a bit of that today, but also a reflection on key research collaborations that I've been able to and privileged to be part of over the last few years, and try to reflect around how it can help to bridge health services and research through networks and collaboration. And I'll use the analogy of a tale of two cities. But before I go any further, I would also like to acknowledge the traditional custodians of the various lands from which we're meeting today, and pay my respect to elders past, present, and emerging. Just trying to. I would like to acknowledge also and recognize the contribution that Indigenous people make to our culture around the world. And being from Canada, it's really important for me to acknowledge especially that contribution to culture. And now living in Australia, recognize that it is a significant contribution to our world and how we manage our planet for the future. So I'll start with a quote from Charles Dickens from A Tale of Two Cities, published in 1859, because I really feel that it's both a quote that reflects a bit our times at the moment, quite disrupted and uncertain, but also at times reflect the feeling that we have when we try to bridge policy and research. He says at the start of his famous book, it was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. It was the epoch of belief, it was the epoch of incredulity. It was the season of light, it was the season of darkness. It was the spring of hope, it was the winter of despair. We had everything before us, we had nothing before us. And I'm not quoting this tale from A Tale of Two Cities to be negative, but instead to really say, like in the book, that actually we can bridge those polar opposites that many people lead us to believe exist, and in reality can be bridged in various different ways. And I'll try to share some of my experience to share with you some of the ways we could do that. So I'll start by talking about the scene, how our research and policies portrayed as dichotomies, and to a great extent our dichotomies at times. Then I'll just reflect on my search, my journey and training, and what led me to be a bit of an hybrid person involved in research, as well as having had various roles in policymaking and public sector organizations. I'll go to the research and really bring for you 4 types of partnership studies that I've been involved in, which I think provide different angles into that potential bridging. And then I'll just reflect on the play. How do we play that game? And reflect on connections and engagement briefly, but really want to keep time for questions and exchange, and therefore some of the play I think will come out of the questions you may have. So please share your questions with us. So research and policies as dichotomies. Just bear with me for a few scene setting slides. So you all know research is about investigation, it's about knowledge generation, and all of this is done by gathering information, observation, trials, and synthesis. Very clear aim. Policy is, in contrast, about continuity or change in practice, very pragmatic. It includes planning, implementation, and monitoring of implementation of change into practice. And evidence-based policymaking really relates to how policy decisions are based upon the best available evidence, and this from a wide range of sources. The lack of use of research in policy is, how to say it, very prevalent. It's still recognized as being very prevalent and seen as a significant contributor to research waste. It's not the only contributor to research waste. Of course, the way we conduct research contributes to that waste, unfortunately. But one of the biggest part of this is for the fact that many research actually are not translated later into decisions that transform the lives of people. And that's the case in healthcare as well. All of this comes from one key assumption, and that's we just need to generate data and information, and that will generate knowledge, and that knowledge will turn into action, and that action will transform healthcare systems and lead into change. But the reality is that this is not such a linear process, and we need to think differently about various things if we are to truly impact healthcare systems through change and action. So what are the barriers to evidence-based policy? And I'm just quoting some factors coming out of O'Dwyer in 2004. So first, at times, there's a lack of access to the relevant evidence, and policy happens in a void, either because the knowledge doesn't exist or is not readily available. Sometimes it's because of prevailing public opinion, and we all know that policy is also influenced by what's acceptable in different contexts, in different cultures. It's at times because of the organizational culture, which may not actually lead to the use of evidence into policy making. It could be around, and that's an important one for us researchers, the incompatible timeframes in policy making and research. Many decisions happen at the wrong time in terms of us being ready to inform them with research And unfortunately, some of the answers that we bring from research happen at the wrong time in terms of being able to inform a decision or a policy. It can stem from values and ideology of both the researchers, which often take the stand of being the holders of the truth, the knowledge coming out of science, but it also comes out of values and ideology of policymakers. And at times you can see anti-intellectualism in this space. Policymakers valuing a lot more the pragmatic and empirical knowledge coming out of the system in comparison to the knowledge coming out of academic research. It's at times about control of power and political goals. It's about the use of research to legitimize policies instead of truly informing them. It's about how far new evidence departs from established or accepted knowledge and how it challenges the paradigms that are prevalent in policy-making realm. And it's at times about how easy it would be to change a policy in light of the new evidence. And if that change is too significant and difficult to make, very often it will not translate into an evidence-based policy. I want to cite this work from Rodriguez and colleagues published in 2017, because to me it was a great summary of how, as researchers, we need to better understand the actual capacity of ministries of health or any other clinical settings to actually use research in decision-making. And in this framework, they identify key individual capacities, key organizational capacities that go alongside the continuum that you can see in the middle, going from the recognition that there is knowledge they could use, the acquisition of that knowledge, getting to know about it, discussing it internally, referring to it, adapting it, and finally using it to influence a decision. And that continuum really requires us to consider key aspects of organizational capacity and individual capacity within those organizations to truly be impactful. So I really advocate for you to look at this study and try to see how some of your research can actually influence that process. How can we support evidence-based policy? Well, it's about revealing the assumptions, the interests, the pressures that affect policymakers as well as researchers right from the outset. I think that's really important that transparency exists right from the start. It's about generating research that is about questions that decision makers may have at specific times. It's about communicating evidence in format and times which are more appropriate for that discourse between evidence and policy. It's about transparency and rigor in methods, co-creation of research at times, knowledge, using knowledge brokers, embedded researchers, and boundary spanners as key actors of that bridging. And to a great extent, I feel that my career has been so far a lot in that space, but in a very specific way. And it's increasingly about living evidence and evidence-based platforms making the evidence readily available for decision makers. So the second part that I wanted to talk about was about around my own search or my own journey and training. So my personal journey really started through a clinical path. I was trained in refugee health and worked at the refugee clinic in Montreal before moving to Australia. I was also trained in public health and preventive medicine and did a lot of infectious disease control as part of that work. And then it very quickly I got very quickly into a research path, very quickly. Did a master's, which was on screening for latent tuberculosis infections at the refugee clinic where I was working. So I was already kind of bridging evidence and policy, being one of the clinicians where the evidence was generated around how to best screen for latent TB amongst refugee claimants. And I then did a PhD where I looked at inequalities in access to healthcare in urban South India, where I was embedded into an economics and development center, which had for aim to generate evidence and knowledge, but also influence policies in the state of Kerala in South India. So very quickly, I got into this path of a dual kind of career. That led me to start my research career proper, evaluating primary care reforms at the Public Health Department in Montreal, then to contribute to primary care reform recommendations for the province of Quebec as part of some of my decision maker roles, and eventually leading me to Australia to lead the Bureau of Health Information and then the Agency for Clinical Innovation that I lead at the moment, where I'm really looking at healthcare innovation and how evidence can be used as part of that innovation process, but also generated through that innovation process. My academic path was really at the University of Montreal for more than 10 years, and then over the last 8 years at the University of New South Wales. So I often joke that ultimately my goal was to find a way not to decide on a specific career and just try to combine everything, because I was so passionate both about generating knowledge as well as using it and really trying to influence systems to change. So I wanted to share in the third and the main part of my presentation some types of partnership studies that I've been involved in that I feel could generate some reflections and thinking for researchers. And they're mostly based around primary care, which is the main area where I've conducted research over the last 20 years. So the first one I wanted to talk about was one where we really tried to harness natural experiments happening in the Quebec context to generate research that would really be in partnerships with decision makers. Because the province was in the midst of reforming its primary care sector, investing a lot of money into new models of primary care, group practices, multidisciplinary, community-based organizations, for example, and the need to actually evaluate those and inform those reforms as they were designed and changed and refined was extremely high. So I had the opportunity to be part of a great research team at the Montreal Public Health Department and the Institute of Public Health in Quebec province, and lead with my great colleague, Renal Pino, who unfortunately passed away last month, this significant longitudinal study looking at the evolution of primary healthcare organizations and their performance in the two most populous regions of Quebec province, Montreal and Montérégie. And what we did as part of that study was really to look at primary care reform and measuring through time both the experience and outcomes for patients going into primary care, but also measuring the actual organization of primary care at the local and at the regional level. And that's what you see there as in this conceptual framework of the various influences that are informing the reform, and in the middle, the various times where we were measuring organizational models, their evolution through time and their performance, and also how at the regional level they were promoting collaboration to take care of complex patients. As part of that study, one of the things we really wanted to do was to find the right voice to communicate the result of the study. And there was lots of products generated through that study all along the 5 years that it lasted. And we wanted to pay attention to the actual type of information that we produce so that it would be really meaningful for decision makers. Because we understood that there was a big distinction between answering a research question and answering a policy question. And we had both objectives as part of this study. And it's really to contribute to the big knowledge, the academic knowledge, as well as the more embedded knowledge. The first one, the academic knowledge being more generic and theoretical, whilst the second one more contextualized and empirical, and really recognizing that answering a research question may actually leave many policy questions unanswered. So that required us to think about the complementary research outputs that we needed to do as a research team. Yes, there were lots of scientific publications around the models, the associations with outcomes and impact, the causation or associations that we saw, but we also produce a lot of local organizational profiles, descriptive tables, rates and variation papers just to show them what was currently happening in those two regions. And of course, also lots of policy briefs to really try to outline what were the implications and how could we translate the findings at the local decision-making level. So for example, as part of one of the studies that was done in that program where we looked at the patient assessment of chronic illness care, we produced that type of graph where we demonstrated that the family medicine group that you can see in the middle of that slide were the ones where the percentage gap was the most positive in terms of mean scores of the PASIC sub-dimensions. So better chronic care management in family medicine groups, quite good results in local community health centers that you can see at the fourth series of bars, but then really not so good results for solo providers on the left, private group practices, the second group of practices, and then towards the right end, the specialist model of care. And really that reinforced how the primary care reform was having an impact and should continue. But that was really just a very descriptive sub-analysis that we did, which was to a great extent not even what the study had intended to demonstrate from the outset. We also produced maps so that we would demonstrate where, for examples, in this case, where there were more unmet needs for primary care, and the dark sub-regions of Montérégie here are highlighted for these, really raising attention to decision makers about the fact that unmet needs for primary care were not evenly distributed in their regions. And again, that was complementary analysis that we did to try to support decision making. That really relates to this notion of synchronous and asynchronous use of knowledge. And the four graphs you can see there are from a paper demonstrating how when we wanted to move from the sundials to generate time, and when we invented the watch, we realized that the sundial was actually creating gaps in knowledge. And we were thinking that it was, 2 o'clock in the afternoon, but the reality is that because of the seasons, it was 2:15, etc. There is very often a gap like this in between policy and research. And even though we very often generate knowledge for asynchronous use, we generate knowledge and publish them in papers so that they can be used tomorrow, but also in 5 years' time. Sometimes we need to make the effort to also support synchronous knowledge. And that's knowledge that needs to happen when the decision maker has got that need for knowledge. The second example I wanted to share was about one where we supported local innovations through research. So it's not that there were natural experiments already happening. We felt that we needed to prompt local areas to be innovative in terms of primary care. And that's work that I had the privilege to conduct with Grant Russell, Jeannie Haggerty, and other colleagues from Australia and Canada, where we designed various interventions and mixed method evaluation of these 6 complex interventions over, again, a 5-year program of work. And that was work funded through Australian and Canadian funding streams. What we did in that project was really partnering with local decision makers to design innovations, implement them, and then evaluate them. And what you can see in this graph, which is the kind of summary of the study, we had 4 main projects. That's the 4 blue bubbles: a scoping of innovation, a synthesis of effectiveness and implementation of these innovations, a mixed method analysis of surveys, and then an evaluation of the locally implemented innovations. And this was done in 6 local innovation partnerships in 3 Canadian provinces and in 3 Australian states, and was really truly an interesting partnerships between decision makers and researchers right from the outset. This one I wanted to use because it really highlights the fact that we need to also think about how we involve people in research if we want to bridge the gap between decision making and research. We need to understand the characteristics of these potential users and build relationships with those users that we most likely will engage with. And that really means we need to understand the decision-making process. When, why, how, where, and for whom do they want to make decision, and create the right interface for these knowledge users to be able to access the information. It needs to really build on networking and knowledge brokering skills as researchers so that we involve decision makers in the research project, and that really promotes better research and better usage, but also use this as an opportunity to knowledge broker about other research projects, because we've got a privileged relationship with the decision maker. And all of this is part of capacity building and knowledge development in policy making. The third example is around co-creation of knowledge, and it's around, this one is a study that we did with Australian and Canadian and American researchers, and it was around uncovering the wisdom hidden between the lines. And what we used as to conduct that study was a collaborative, reflexive, deliberative approach. And I'll just take a minute to describe what it was. Basically, what we did in that study was to bring a group of researchers and decision makers from these three countries, Australia, Canada, and the US, and go through a process where the researchers would talk about and unearth findings from their original published studies and reanalyze them together through a process of organizing and reinterpreting those studies, and then integrating that knowledge in collaboration with decision makers. So what we were doing is we identified new research questions that were not part of the original studies, but we felt that the studies could actually answer those questions collectively. We reanalyzed the material collected as part of these original studies as secondary analysis, and created new knowledge through an iterative process of deliberation with the decision makers. And this was an amazing way to actually generate new knowledge from studies that were never intended to generate that knowledge, and make sure that we would use that material, maximize its outputs and its benefits to answer current questions that the decision makers had from these different jurisdictions. It's not too dissimilar to deliberative processes where, and that's coming from other studies where I was involved, where decision makers and researchers would sit together, look at the outcomes of the studies, and generate new knowledge through a deliberative process. And I'm just going to share with you an output from one of these deliberative processes that I've been involved in, where we reflected on primary care reforms with various decision makers and researchers from all of the provinces and territories in Canada, and identified what were the components of primary care reforms that were well covered in each of the provinces and jurisdictions reforms, and basically did a synthesis out of studies that didn't exist yet through that process, and really harnessing the knowledge from various studies and from decision makers into that synthesis. And again, a very, very rich process that I would recommend to anyone to go through. Finally, I just wanted to reflect on also the fact that we are involved in actually studying the process of improvement. And I think that's something really required in many sectors. And that example is not solely from primary care. This is really an example from a significant study that we're doing in collaboration with Macquarie University and various other organizations around evaluating 7 natural experiments happening at the moment in New South Wales Health. And the objective here is really to try to contribute to what we call the pipeline of innovation, to progress grassroots innovations to high quality small scale tests, high quality mid-sized tests of spread and scale, and then eventually to large scale implementation and evaluation. You really need to learn about what facilitates that process, what are the studies and research required to progress towards that large scale implementation and evaluation, so that we really inform the pilot, spread and scale continuum. So I just want to finish with a few slides around the play. What are my reflections around trying to build those connections and disengagement over the last few years. And I want to start by reflecting on the fact that one of the things that has been very useful for me is to actually try to build a logic model of my research, not the logic model of what I want to evaluate or study. No, the logic model of how do I think my research is actually going to change anything? What's the role of papers in the scientific literature? What's the role of engagement meetings with decision makers? What's the role of conducting complementary analysis outside of the scope of the study, but complementary analysis that I know may actually inform a decision? And just like this specific logic model where parents tried to reflect how to throw a birthday party at their house flat so that it's enjoyable for their 3-year-old daughter and their friends, they tried to really identify what are the activities, short-term outcomes, intermediate outcomes that would contribute to the long-term outcomes that would be they would feel comfortable to have birthday parties in their house in the future. I think we need to reflect on how are our research actually going to make any change. It's also about trying to see what's our role as researchers in trying to bridge research and policy. And Gladwell proposed that there were 3 types of bridging roles. The first one being connectors, and these are networkers, and he suggests that they know who to pass information to and are respected, so will have influence on key players. The second role are the mavens, and these are the information specialists. You know, they know a lot of stuff, and they acquire that knowledge and then educate others about it and influence others through this role. And finally, there are the salesmen, the powerful, charismatic, and persuasive people that are trusted, believed, and listened to in areas where others would actually be ignored. I think to some extent, I've tried to be a maven and a connector in my role, really trying to build networks along the way, preserve those networks, and very often through friendships, in addition to professional networks, and then also play a role as a maven, really trying to influence through that knowledge and information that I was privileged to have access to. So some key insights from my experience. I would say that it's really possible to combine research and policy. The opportunities to engage in participative research with decision makers are both challenging and rewarding, and I would really encourage you to pursue these and persevere at trying to make them happen. However, it's clear that the current funding models, with either on one side translational research programs, or on the other side, the NHMRC and MRFF more fundamental kind of programs, do not truly open the doors to these kinds of partnership research, and seeking alternative or complementary funding to these models is extremely important. A lot of many of the studies I talked about in this presentation have actually been done with significant investments from academic funders, but alongside significant investments from ministries and regional health authorities that wanted to see change happen alongside evaluation and knowledge generation. Conduct research with both the policy and the scientific questions in mind. That's very important. Convince funders that you have a great scientific question, but keep in the back pocket the policy questions you may be able to answer as well. And these will attract the policymakers. And finally, design products for decision makers all along the way. Don't wait 3 years to provide a report back to decision makers. In all of this, boundary spanners such as myself may actually assist in bridging the gaps. And there are people like this in the system. You need to find them. So to conclude, I really encourage you to engage with stakeholders to develop relationships, and those should be on the long term. Remain humble about the value of research, because the reality is that a lot of the studies we conduct have a lot of limitations, may not be fit for purpose for the questions decision makers have, and we need to somehow bend the usual academic process if we're to provide the answers that will bring value to decision makers. Remain rigorous, that's very important, but also agile. And one of the ways to be agile is to actually have a portfolio of options and a great network of academic friends and colleagues to mobilize to bridge that gap. Be generous with your time, and I know that our careers are very demanding, but sometimes what's needed is now, and it doesn't need to be perfect if it's to be timely. And in return, respect commitments. Do have the meetings even if the results are not panning out as we had expected. Negative results are as important for decision makers as the positive associations we may find. Choose strategically because all of this is time consuming, and you really need to partner with people that you know you'll have a great relationship and a great collaboration emerging. And many of my colleagues and myself have used, you know, if you wouldn't want to have a dinner or a beer with that person, it may not be a good collaboration on the long term. Finally, communicate your expectations and the perceived barriers that may come along the way, because that's the way you can preserve the relationships. Very often, talking about those expectations and barriers just helps people to understand what everyone will actually take out from the collaboration. So on this, I will stop and hope that this has raised questions for you, reflections, and I'll be happy to provide more details. I understand that this is a very quick tour and a lot of material to share. Thank you.
All right, thank you so much for that presentation, Jean-Frédéric. I think those were some very thought-provoking points. We'll now open the floor for questions. Just
and I'll
checking.
stop sharing.
Yeah, and just checking the Q&A box. We don't have any questions yet from the audience, so I might kick it off with one of my own. So my question to you would be, what advice do you have to early career researchers looking to connect with or partner with potential collaborators in government who may not have those contacts yet? Where can they start?
Yeah, well, of course, you should start with key senior researchers that have had a track record of engaging meaningfully with decision makers. Not all researchers have that talent, honestly. Many of them recognize that they don't have that talent, and they actually partner with others to make this happen for their research teams. But there are really some people that have this knack, and that could be a good start because you will be introduced to people that will be interested in your studies in the policy realm, but also they will use tricks and you will learn from them. So finding those mavens, I think, is something I would be looking for. And basically, you need to be on the lookout. You be on the search. Asking your mentors and colleagues, who they would recommend to actually be the right introduction to all of these people. And come with your bright ideas, because very often you are the new generation that comes with those questions that have not been answered yet. You don't have all of those paradigms weighing on your shoulders. It's a great moment to actually engage with decision makers, remaining humble, but also confident that you've got something to bring to the table.
That's some really good tips there. And there's a couple of ECRs asking similar questions there. So I think that's really touched a key point for people. I was wondering, Jean-Fred, whether you can talk about if people are doing research that I guess isn't politically palatable and is the tricky research, does that mean you just kind of give up on that topic, go a different way, or is there any tips you have there?
I think the reality is that very often there is a decision maker somewhere embedded in one floor of the ministry or a regional health authority that will have an interest in some of the less, mainstream kind of reform agendas. It's also about trying to connect through academic organizations like AAAPC or other organizations and really be proactive at sharing what is it that you think you have to contribute and what are the partnerships that you are looking for, and then see what happens. I think also that it means that it's important for organizations like AAAPC and others to really reflect on what are the activities that would create that connection because it needs to be showcased. You know, very often we don't even know that there's a researcher locally that has got that great idea, that great program of work. And if that researcher expresses the, you know, the openness to be influenced in return, I think that can really create a great conversation.
Fantastic. And we have some questions from the audience. So Hasai is asking, how do you manage the different cultures of research and policy?
Yeah, well, that's what it's not easy. And that's why I use that quote at the start, because at times you really feel that you're in continuous dichotomies. I mean, you know, sometimes I'm at a specific table as a policymaker, and I feel that being a researcher at the same time is really helping the discussion to progress in a way that bridges some of that gap. And at other times I'm at the research table and can really try to share my experience being a decision maker at the same time, and really try to you know, translate this in that gap. I know that not everyone has got that privilege of being where I am. And therefore, it really needs to engage in ongoing conversations so that you get that understanding about, you know, what is the discourse of decision makers, what will make them totally disconnected and they will stop to listen, and whilst in return, what will make them interested in asking more questions. And I think that it's a skill that needs to be developed. I had to build it because of my roles, and that led me to be part of those studies that had that specific angle and that specific contribution. But it didn't start like this 20 years ago. You know, I had to seek out these kinds of knowledge and roles, and really build the competencies. So it's something that it's, you know, if it's part of your interest in your career, that's something that can be gradually built.
We have another question from Joanna Lynch. So she's picked up on the topic of funding, and I was actually really surprised actually to hear you talk about, you know, NHMRC, MRF not being perhaps set for purpose here. And she's also wondering if you have any input or insights into changes in research funding that seem to be prioritising embedded clinician researchers and partnerships with real world outputs as a priority.
Yeah, I mean, I don't want to be too dismissive. You know, I do think that, you know, MRFF funding, for example, it does open the door to different types of projects being led, etc. But I've not seen yet a lot of researchers where the MRFF was generated out of a real world kind of natural experiment, and then the research team would make themselves available to conduct the studies alongside that natural experiment, for example. And I feel that it should, you know, there should be streams of work planned in this way, where you know, ministries could be contacted to actually say, you know, do you have a multi-million-dollar reform agenda that, you know, needs research, and we could actually co-fund it together. I think, you know, and I don't want to be too biased by my origins, but I think that there's been more attempts at creating those programs in the Canadian context. I think in Australia, as a research community and as a community of decision makers, we need to continue to push this agenda so that it's increasingly on the table. The partnership grants, I think, can have a role. It's not perfect. MRFF for sure. NHMRC, much more difficult in terms of health systems research. You know, we have to be honest with this. So I think that there's more that can be done. And maybe some of the research team can actually be the link to make it happen. If you're aware of a big reform and a big policy, again, I would encourage you to be proactive, contact them and say, you know, is there something we could do with some of those research streams to help you do more evaluation on these programs through that, you know, partnership and academic funding that may come.
Fantastic. So we have a question from Renee. So she is asking, as ECRs, we often don't have many options for who we get to partner with and often have to take what we can get. or won't know what a person is like until we are months or years down the track and then learn the hard way. So do you have any tips besides the dinner/beer option on how we determine who is good to partner with?
I would say that sometimes it's the track record that is the best indication. You know, have they published a lot of academic papers, but not so many reports that are, you know, more descriptive, linked up and done either commissioned or sponsored by a government agency? Do they have any roles in government? You know, either as part of specific strategic committees or advisory roles, you know, etc. And just like when you select a, you know, a PhD supervisor, you know, ask questions, and their answers, I think, is going to reveal if there's a potential partnership and collaboration that will be fruitful. You know, are they real agents of change? And if they're agents of change and translation, they will have a track record, and it can be visible. So they need to be good people for sure, but they also need to be effective people, and that's what that's the tips I would give, in addition to the, you know, are they good persons? Are they people that you would have a dinner or a beer with?
The conference dance floor is also good, Jean-Frédéric, for finding good friends.
Absolutely, especially at Knapcrag.
Used to be.
Used to be, yeah.
One day. And perhaps our last question tonight, Jean-Fred. So from Annette Piet, thanks for your presentation. And while you didn't touch on this directly in your presentation, I was wondering if you'd talk a little about your access to care model. Do you know how this has been enacted or used in your boundary spanning role? And if you had your time over, what would you change about the model? Ooh.
That's a good question, Annette. My God, it's certainly a framework that has had quite a lot of academic success, I have to say. But what makes me really proud is the fact that it has also been used in policy. So, for example, it's been used in some Indigenous studies and implementation work in Canada and in Australia. And it has been used in many programs where people wanted to improve access for a very vulnerable group. So it's been used in sexual health, especially amongst teenagers. The model has been used with refugees, which is, of course, something that made me very, very proud and happy to have done that work. Because fundamentally, the model highlighted the fact that we cannot ignore the fact that people have various abilities to access healthcare. And if we don't consider them, then we can design healthcare in a way that's really disconnected from those abilities and discrimination that they're facing, and therefore will not have a very strong impact. What I would do different over time, what I would change about the model, I think I would make it more explicit that there's a lot of layers into this, and it's not just about the primary care organization and the individuals. It's also about society. It's also about the overall systems and some of the barriers that it puts for some of those populations. It's not absent from the model, but it's somehow embedded in the text, and the visuals that we've used to convey the conceptual framework, I don't think is making this visible enough, and therefore not enough the attention, the subject of attention of some of the policies. So that's certainly something I would look differently, and that's something that Grant Russell and Mark Harris and myself have discussed over time as well. So thanks for the question, Annette. It's work dear to my heart, and it's work that came out of my inequalities in access to healthcare in urban South India, and that's certainly a context where I felt if we don't talk about the agency of people, we will never increase access for those people.
Fantastic. So I guess we can look forward to an update on the 2013 paper, Jean-Fred.
It's somehow in the cards, but there's also been a lot of work recently looking at how it has been used in different studies, the measurement tools that were used to actually capture the essence of the model, because the model doesn't come with a complete toolkit, etc. And I think that as a group of researchers, we will learn a lot from those two streams of studies around the access framework, and I'm waiting for this to really try to do the next round on the conceptual framework. It needs to be informed by this work currently happening in the field.
Yeah. Great. So I think that's all the questions. So I just wanted to say thank you to everyone for participating tonight. And of course, a huge thank you to you, Jean-Fred, for your time. We already have some fantastic feedback in the chat box. So if you enjoyed tonight's webinar and you're not a member yet, please head over to AAAPC.com.au for more information on membership and events. We also have an upcoming conference that's happening in August, so please make sure you check that out as well. Okay, great. I just want to say thanks again, and good night, everyone, and stay safe.
Thanks for the opportunity to talk to you all tonight. Thank you.
Thank you.
Being a primary care academic is a joy and a privilege. I've had the opportunity to have so many roles: clinician, researcher, teacher, writer, editor, presenter, leader, team member.
I love academic primary care because it's really fun to work in a collaborative research environment. It is super exciting to discover new knowledge in order to improve healthcare outcomes for our patients.
Academic primary care for me is a place where I can find my passion and develop. It is also the place where I can find friendship,